Welcome to the deep dive. Our mission today, to really cut through the complexity of one of the most clinically critical chapters in pharmacology, women's health drugs. We're aiming to distill the core knowledge, give you the high-value takeaways on drug classes, mechanisms, and maybe most importantly, the non-negotiable nursing essentials you absolutely need to master.
It's definitely a wide field. But the central theme running through all these compounds, we're talking estrogens, progestins, contraceptives, even things like osteoporosis treatments and uterine motility agents, it all comes back to hormonal balance.
Hormonal balance.
Exactly.
Yeah.
We are basically looking at agents designed to intentionally restore or sometimes interrupt or even leverage the body's really delicate regulatory feedback loops.
Okay. So let's unpack this by maybe setting some foundational context first. We're talking about the reproductive cycle, right? Defined by events like menarche, that's the first menses, and then later menopause, the cessation of menses.
And you also have terms like the corpus luteum. That's that temporary structure after ovulation, the one that secretes progesterone.
Right. And we should probably mention side effects too, like chloasma or melasma, that hyperpigmentation you can get from some hormonal drugs.
Yeah, that's a common one. And that whole cycle, it's governed by a really tightly controlled feedback system. It originates from the pituitary gland,
The pituitary, okay.
which releases the gonadotropins, follicle-stimulating hormone, FSH, and luteinizing hormone, LH. And these basically regulate the production of estrogen and progesterone by the ovaries.
So if we try to visualize that process, what's happening with those hormone levels over, say, a typical 28-day cycle?
Well, you can break the cycle down into roughly 4 parts.
Hmm.
After menstruation, you enter the follicular phase or proliferative phase. That's where rising estrogen levels stimulate the endometrium to grow.
Got it.
Then around day 14, you get this massive surge, a big peak of estrogen, FSH, and LH, and that results in ovulation.
That's the trigger.
Exactly.
Right.
And following that, the luteal or secretory phase kicks in. This is when the corpus luteum, remember that, secretes large amounts of progesterone. Its job is to prepare the uterus for a potential implantation.
So the whole system is characterized by these dramatic peaks and valleys in hormone levels.
Precisely. And those are the peaks and valleys we're aiming to either mimic or sometimes suppress with pharmacology.
Okay, so if that natural feedback loop is so central, what happens when we intentionally mess with it or try to restore it? Let's start with the heavy hitters, estrogens. The main one the body makes itself is estradiol, right? But in the pharmacy, we see a whole range of other forms.
That's right. Estradiol is the most active naturally. But for drug therapy, we often rely on versions like conjugated estrogens. The most famous one is probably Premarin, which was originally derived from pregnant mare's urine.
Right, I've heard of that.
Though, products like estrus, which come from plant sources like soybeans, are also common now. And then there's ethinyl estradiol. It's highly potent, and it's the estrogen component you find in many oral contraceptives.
Okay, so give us the core mechanism. How do these actually work? How do they fundamentally change things in the body?
Well, estrogens are kind of unique because they bind to receptors inside the cell, intracellular receptors. And this binding ultimately stimulates the synthesis of nucleic acids, DNA and RNA and proteins.
So they're basically drivers of tissue growth.
Essentially, yes. And beyond the obvious role in, feminization and secondary sex characteristics, one really crucial physiological effect is their cardioprotective effect. It's thought to be tied to their ability to lower LDLs, the bad cholesterol.
And the uses are pretty widespread then, treating classic menopausal symptoms like hot flashes, atrophic vaginitis, but also contraception, preventing osteoporosis, even cross-gender hormone treatment.
Yes, the indications are broad.
But here's where we hit the big safety issue, right?
Exactly. The critical risk with estrogens isn't just, minor side effects. It's hypercoagulability.
Meaning increased clotting risk.
Precisely. Estrogen enhances platelet activity and increases plasma fibrinogen levels. This leads to a serious risk of deep vein thrombosis, DVT, stroke, and pulmonary embolism, PE. And this risk really was the foundation of the Women's Health Initiative, the WHI findings that caused such a massive shift in prescribing habits years ago.
That's the key takeaway, isn't it? The WHI study. What was the central finding that just redefined hormone therapy?
I think the single biggest insight from WHI was that the benefit-risk profile changes dramatically based on when you start the therapy. Combination estrogen-progestin therapy was found to increase the risk of breast cancer and stroke.
Okay.
And even estrogen-only therapy increased stroke risk. But, and this is important, the recent consensus, including the update from the North American Menopause Society, or NAMS, emphasizes this timing window.
The timing window.
Yeah. The benefit-risk ratio seems favorable for individuals who start hormone therapy relatively soon after menopause begins, but the risk significantly increases the longer someone waits to start. So it really demands an individualized risk assessment for every single patient.
That distinction, the timing of when you start that seems invaluable for clinicians. Okay, moving on then. Let's look at progestins. Progesterone is the most active natural one. What are the key synthetic versions we see, and how do their uses differ?
Well, we often see medroxyprogesterone, commonly known by the brand name Depo-Provera. That's widely used for contraception and also for managing secondary amenorrhea.
Right, the injection.
Exactly.
Yeah.
But then there's another one called Magestrol. It's also a synthetic progestin, but its main clinical use now isn't always strictly hormonal regulation. It's often used in palliative care.
Palliative care, how so?
It's used to stimulate appetite and help manage unexplained weight loss, particularly in patients with advanced cancer or AIDS.
Huh. It's interesting that a synthetic progestin has kind of shifted its primary use like that. Does that dual function complicate things for clinicians?
It definitely highlights how diverse the functions of these steroid hormones can be. The mechanism of progestins, unlike estrogen, really focuses more on preparation. They induce secretory changes in the endometrium, they diminish tissue proliferation, and they actually relax uterine smooth muscle.
Okay.
And pharmacologically, they provide a powerful negative feedback to the pituitary, suppressing that FSH and LH release we talked about earlier.
But they still carry risks.
Oh, yes. Adverse effects can still include things like liver dysfunction, you might see jaundice, and also thrombophlebitis, and those thromboembolic disorders, similar to estrogens.
Okay, let's talk combination therapy then. Oral contraceptives, the pill. They come in these complex forms, monophasic, biphasic, triphasic, even extended cycle formulas, typically combining ethinyl estradiol with progestin like northindrone.
Right. And their mechanism is really twofold, which makes them highly effective. First, they inhibit the release of those key gonadotropins, FSH and LH, which basically prevents ovulation from happening at all.
Stops the egg release.
Exactly. And second, they increase the viscosity of the cervical mucus. This acts like a physical barrier, making it harder for sperm to move through and also harder for implantation to occur, even if fertilization somehow happened.
We should also probably mention postcoital contraception here, like levonorgestrel or Plan B. That needs to be taken within 72 hours, right? To prevent implantation.
Yes, that 72-hour window is absolutely crucial for its effectiveness. And going back to the regular pill, the really critical nursing rule, the one you must teach patients, is about drug interactions.
Ah, yes. What should people know?
Backup contraception is necessary when taking OCs concurrently with certain other drugs, especially enzyme inducers, things like some penicillins, rifampin, or barbiturates. These drugs speed up the metabolism of the hormonal agents in the pill, potentially making it less effective.
That's a huge teaching point. And what about absolute contraindications? When should clinicians be extremely cautious or avoid OCs altogether?
Well, primarily because of that thrombosis risk we keep mentioning.
Yeah.
Oral contraceptives are generally contraindicated for anyone over the age of 35 who smokes.
Okay, smoker over 35, big red flag.
A big red flag. Also, individuals with any history of thromboembolic events, DVT, PE, stroke, and often caution is advised for those over 35 who suffer from migraine headaches, particularly migraines with aura, as this has been linked to an increased stroke risk as well.
Okay, that's clear. Let's pivot now quite sharply to skeletal health. Osteoporosis. We know it means low bone density, thinning tissue, much higher fracture risk. And the stats in Canada are pretty stark. Something like 1 in 3 people born with a vulva, 1 in 5 born with a penis will suffer an osteoporotic fracture.
Yeah, the prevalence is high.
And prevention, of course, starts with the basics. Calcium about 1,200 milligrams a day for over 50s, and vitamin D maybe 800 to 2,000 units daily for the same group. But what about when bone loss is already established? What are the main drug strategies?
We generally use 4 distinct classes. Let's start with the most common ones, the bisphosphonates, like alendronate Fosamax is a common brand name.
Okay, bisphosphonates, what do they do?
Their goal is to inhibit the activity of osteoclasts. Osteoclasts are the cells responsible for breaking down bone tissue. So bisphosphonates basically slow down bone resorption, helping to maintain or enhance bone mineral density.
Right, and I remember the non-negotiable role for taking alendronate being drilled into us in school. Why is taking it with a full glass of water and then staying upright so absolutely critical?
Ah, yes. That's probably the single highest alert patient teaching point for this entire class of drugs. The pill itself is actually quite corrosive.
Corrosive.
Yes. If it lodges in the esophagus, even for a short time, it can cause severe esophageal burns and irritation. So that 30-minute upright period after taking it is absolutely mandatory, no lying down.
Wow, okay. Good to know. Are there other serious risks?
Yes, we also need to monitor for rare but serious risks, like osteonecrosis of the jaw ONJ. This is seen more often with the intravenous forms, but can occur with oral ones. And also, paradoxically, atypical femur fractures have been reported with long-term use.
Okay, that's bisphosphonates. What's the next class?
Next up are the Selective Estrogen Receptor Modulators, or SERMs. The key example here is raloxifene.
SERMs. How do they compare to just taking regular estrogen?
Well, they're selective. They act like estrogen on bone tissue, stimulating those estrogen receptors to help increase bone density. But, and this is the key difference, they tend to block estrogen receptors elsewhere, for example, in breast tissue, which can be beneficial.
Ah, so targeted action.
Exactly. However, because they still have some estrogenic activity, they unfortunately still carry an increased risk of venous thromboembolism, similar to estrogen itself.
So clotting risk again.
Right. And this means a patient taking raloxifene must discontinue the drug 72 hours before any period of prolonged immobility, think of major surgery, or even just a long plane trip.
Another crucial counseling point. Okay, 2 more classes for osteoporosis.
Yes, 2 slightly different approaches. We have teriparatide. This one is unique because it's the only agent we've discussed so far that actually stimulates bone formation. It helps build new bone, rather than just stopping bone breakdown.
So it builds bone up.
Correct. It's usually reserved for patients who are at the very highest risk of fracture. And then lastly, there's denosumab. This is a monoclonal antibody given as a subcutaneous injection usually every 6 months, and it works by blocking the activation of those osteoclasts we talked about earlier.
Quite a range of mechanisms there. Okay, let's wrap up our drug tour with uterine motility and fertility. We're talking about drugs that can either start labor, enhance it, or even stop uterine bleeding after birth. The oxytocics includes things like ergot derivatives, prostaglandins, and the hormone oxytocin itself, which I notice is classified as a high-alert drug.
Absolutely. Oxytocin is very potent. Its main uses are to induce labor when needed or to augment labor that isn't progressing well. It's also crucial for preventing dangerous postpartum hemorrhage and sometimes used to manage incomplete abortions.
And the prostaglandins, like dinoprostone or misoprostol?
Right. Prostaglandins are primarily used to ripen the cervix, basically make it softer and more ready for labor. Clinicians often use something called the Bishop score to assess cervical readiness before deciding to use them. They can also be used to induce abortions, particularly in the second trimester, and the ergot alkaloids, like ergonovine, are mainly used to prevent postpartum uterine atony, that boggy uterus that can lead to hemorrhage.
Okay, given that oxytocin is high alert, what does the necessary monitoring involve? That sounds critical.
It is critical. Because oxytocin can cause excessively strong or hypertonic contractions, it requires continuous, really minute-to-minute monitoring. We need to watch the mother's blood pressure, her pulse, the frequency and strength of contractions, and absolutely critically, the fetal heart rate via continuous electronic fetal monitoring.
Constant vigilance.
Constant vigilance.
Yeah.
And another major contraindication, combining any oxytocic drug with sympathomimetic drugs, things that mimic the sympathetic nervous system, is strictly contraindicated. The risk of severe hypertension is just too high.
Good to flag. Okay, and finally, briefly, what about drugs used for fertility, specifically for an ovulation?
These agents, examples include gonadotropins, which is actually a mixture of FSH and LH, and gonadotropin alpha, which is a recombinant form of HCG, human chorionic gonadotropin. They essentially work by stimulating the pituitary to release more gonadotropins or mimicking the natural LH surge.
To trigger ovulation.
Exactly, to promote follicular development in the ovary and ultimately induce ovulation. The main adverse effect that clinicians really need to monitor for is something called ovarian hyperstimulation syndrome, or OHSS, and naturally there's an increased chance of multiple pregnancies, twins, triplets, etc.
Okay, so if we step back from all these specific drug names and classes for a moment, what does the nursing process section of a chapter like this really emphasize about starting any of these kinds of hormone therapies?
Well, the initial assessment is absolutely paramount. Before starting anything, you need a complete baseline. That means checking blood pressure, weight, getting a thorough allergy history, and a full medical and menstrual history.
The groundwork.
Exactly. And then implementation really involves detailed patient teaching. Simple things like taking oral hormonal drugs with food to maybe lessen GI upset. But most critically, patients must know how to monitor themselves for signs of serious adverse effects.
Like what specifically?
Things like hypertension, maybe checking their blood pressure if appropriate, any signs of edema or fluid retention, And crucially, any symptom that might indicate a thromboembolism, sudden severe leg pain, calf tenderness, sudden chest pain, shortness of breath, or sudden vision changes, those need immediate medical attention.
It really underscores that the complexity here isn't just knowing the drug names, it's understanding the profound systemic safety implications of every single one of these classes, whether you're regulating bone density, managing fertility, or inducing labor.
Absolutely. That core understanding of hormone balance and the potentially high risk of disrupting it, even intentionally, that's the essential takeaway, I think.
Which leads us maybe to a final thought for our listeners to consider.
Yeah, something to mull over. Given that the source material does mention concerns about potential bone density loss with long-term use of Depo-Provera, particularly in younger individuals, say under 25.
Right, when they're still building peak bone mass.
Exactly. And we know how critical estrogen is for achieving that peak bone mass in early adulthood. So the question becomes, how should future clinical practice balance the immediate need for effective contraception in young patients with these potential long-term risks to their skeletal health down the road?
That's a really critical question, isn't it? Balancing immediate patient needs with health outcomes that might not show up for decades. A tough clinical balancing act. Well, we hope this deep dive has given you a clear, concise pathway through this really essential area of pharmacological knowledge. Thanks for joining us.